This talk is about Coma. These are the objectives of this talk. You do not need to read them at this point. We will address each of them as we go along. The first objective is to define and explain the pathological processes producing coma, stupor, obtundation, lethargy, delirium, and dementia. Before starting the body of this talk, I'd like to show you the photograph of a patient that I took care of quite a few years ago. She was the daughter of a doctor friend of mine. She was comatose. She was intubated on a respirator. Her intracranial pressure was being monitored. Her eyes were kept shut by scotch tape to avoid corneal ulcerations, and she had skin lesions not only in her face but also in the rest of her body. At the end of this talk, I will tell you her diagnosis and outcome. So let's start. Mental status has two components: arousal and content of consciousness. In this talk, we will mainly address failure of arousal. To do so, I will introduce this anatomical model. This is a representation of the central nervous system. The brain, right hemisphere, left hemisphere, thalamus, diencephalon, cerebellum, midbrain, pons, medulla, and spinal cord. Now I want to call your attention to the pons, specifically to the upper half and to the midbrain. In the core region of the upper pons and midbrain, we find a structure formed by neurons intermingled with strands of fibers that, upon reaching the diencephalon, divide and ascend, reaching the thalami and becoming the reticular nuclei of the thalamus. The activation of this structure, working in conjunction with the cerebral hemispheres, keep us awake. How is this important structure called? This structure is called the ascending reticular activating system. It's called ascending because its main output is rostral. It is called reticular because when viewed under a microscope, its structure consists of rete of single or few neurons together intermingled with nerve fibers, as shown in this specimen. In it, you can see neurons not packed close enough to form a nucleus, adjacent to fibers packed not tightly enough to be called tracts. It is called activating because it activates the cerebrum, and it is called a system because it is considered a structure based on functional cohesiveness rather than anatomical compactness. Where do efferent connections from the ascending reticular activating system go? From our previous discussion, you can guess that the efferent connections go to the cerebral cortex. Where do the afferent connections to the ascending reticular activating system come from? The afferent connections come from the spine, the brain stem, and from the cerebrum. What type of lesions produce arousal failure? Arousal failure can be due to a relatively small single midline lesion in the upper pons or midbrain, or due to diffusely severe, rather acute bilateral cerebral hemispheric disease. What type of brain or brainstem lesions do not produce arousal failure? Brainstem and cerebral lesions not producing arousal failure, despite occurring within the temporal window of those that do, are those that selectively involve the lower pons and medulla, even if the midline is involved, those in the upper pons and midbrain, sparing the midline region, those affecting only one cerebral hemisphere, those affecting the cerebellum, and those affecting the spinal cord. The bottom line is that arousal failure occurs with bihemisphere cerebral involvement or midline lesions involving the midbrain or the upper pons. What are the clinical manifestations of arousal failure? I will name 5 manifestations of arousal failure and say a few words about each of them in the next few minutes. But before I do so, I want you to know that in different textbooks, you will find significantly different terminology and also significantly different definitions used for the conditions producing arousal failure. Here, I am including the definitions I find more useful because they are based on answering 3 simple questions. What stimulus is needed to awaken the patient? How long the awake period lasts in relation to the stimulus? And what can the patient do while awake? So here we go with the first condition. The most severe clinical manifestation of arousal failure is coma. Comatose patients cannot be awakened by any stimulus including pain, but they must have some brainstem function. Unresponsiveness to any stimulus including pain with no brainstem function is in the right setting is an indication to initiate a brain death protocol or to confirm brain death after meeting other brain death criteria. What type of lesions produce coma? A comatose patient has, as we just heard, signs of severe diffuse cerebral cortical dysfunction. I am representing this degree of severity, the highest, by using a bright yellow color at the rim of the cerebrum. Coma is the result of 3 types of pathologies. One is a single relatively small midline structural lesion in the upper pons or midbrain. The second type of lesion producing coma is a single hemispheric cerebral lesion leading to an uncal herniation that involves the ascending reticular formation in the brainstem, or 2, a subpulsing herniation, those involving the contralateral hemisphere. The third type of lesion is a diffusely bilateral hemispheric lesion resulting from a metabolic disease, here depicted in red. After coma, the second condition in decreased severity is stupor. A patient with stupor is awakened by pain. The awake period lasts as long as the stimulus is being applied. And while awake, the interaction is minimal, usually limited to mourning and occasionally to withdrawal movements. Stupor often precedes coma. What type of lesions produce stupor? A patient with stupor has severe diffuse cerebral cortical dysfunction, but less severe than patients with coma. I am representing the lesser degree of cerebral dysfunction by using a darker shade of yellow than I use to represent the degree of cerebral dysfunction in coma. Stupor is the result of the same type of lesion producing coma. After stupor, we will talk about obtundation. Obtunded patients are awakened by loud noise. The awake period lasts as long as the stimulus and a little bit after the stimulus stops. While awake, the interaction is moderate. Usually, they can say incongruent words and localize pain. What type of lesions produce obtundation? A patient with obtundation has less severe diffuse cerebral cortical dysfunction than a patient with a stupor. Cerebral dysfunction is here represented by a darker shade of yellow. Obtundation may be seen early in the course of structural lesions destined to produce deeper stages of arousal failure, or metabolic disorders affecting both hemispheres. After obtundation, we will talk about lethargy. A lethargic patient is awakened by normal, strong stimuli such as touch or loud voice. Wakefulness lasts for a significant amount of time beyond the stimulus, and while awake has fair interaction, usually answering simple questions appropriately. What type of lesion produces lethargy? A patient with lethargy has less severe diffuse cerebral cortical dysfunction than a patient with obtundation. Cerebral dysfunction is here represented even by a darker shade of yellow, as you can see. Lethargy is most often produced by metabolic diseases, but may also occur as an early symptom of a structural lesion in the brainstem or unilateral hemispheric lesion producing herniation. After lethargy, we will talk about delirium. The manifestations of delirium consist of disorientation, trepidation, illusions that result from misinterpreted stimuli, and hallucination, that is incorrect perceptions not related to any stimulus. A patient with delirium has bilateral patchy cerebral cortical dysfunction. Cerebral dysfunction is here represented by patchy area, color dark yellow. Delirium is usually seen early in the course of metabolic diseases destined to produce more severe type of arousal failure, but they can also occur early in association with structural lesions. The conditions we have been talking about so far have dealt with arousal problems. Dementia, on the other hand, is also a problem with mental status, but not with arousal. Dementia implies a content of consciousness alteration. The altered content of consciousness in dementia patients manifest by a disruption of cortical function involving memory and at least one or more cognitive domain. The disruption should be severe enough to produce significant social and occupational impairment. The disruption can be progressive, static, or reversible, depending on the etiology. A patient with dementia may have bilateral patchy or uniform bilateral cerebral cortical dysfunction. So we have finished the first item. We will start the second item. List the steps needed to perform a Glasgow Coma scale. As you have probably figured out from this talk so far, the definitions we have used lack precise boundaries. This shortcoming has triggered the development of more precise terminology. One, numerical, the Glasgow Coma scale and the other one descriptive, based on anatomical localization. We will first address the Glasgow Coma scale. This scale scores 3 categories of responses and yields from 3 to 15 points. The category of responses are eye-opening response. Eye-opening response yields from 1 to 4 points. Verbal response yields from 1 to 5 points. And motor responses yield from 1 to 6 points. I will now explain when these points are given. During testing eye-opening response, 1 point is given for no eye opening despite most intense stimulus. 2 for eye opening to pain. 3 for eye opening to speech. And 4 for spontaneous eye opening. During oral response testing, the patient will be given 1 for no verbal response, 2 for making incomprehensible sounds, 3 for inappropriate words, 4 for confused speech, and 5 for appropriate speech. Appropriate speech includes the patient being oriented in time, person, and place. During motor testing, the patient will get 1 for no response, 2 for extension of the limb being stimulated, 3 for abnormal flexion of the limb being stimulated, 4 for withdrawal flexion, 5 for pain localization, and 6 points for obeying commands, such as touching his nose on command or moving a leg. This apparent simple scale, most neurologists I deal with think that it should be used to follow progression of coma and not for other purposes such as diagnosing or guiding plan of treatment. As a matter of fact, the developers of the Glasgow Coma Scale stated in 1978, "We have never recommended using the Glasgow Coma Scale alone, either as means of monitoring coma or to assess severity of brain damage or predict outcome." Yet in clinical setting, despite these cautions, the Glasgow Coma Scale score is often used for diagnosis of coma if the patient is not able to open the eyes, to speak, or obey commands. That is, coma is diagnosed if the patient scores 7 points or less. Before dropping the subject of the Glasgow Coma Scale, I like to mention that this scale cannot be used in patients with significant eye swelling, nor in patients that are intubated or paralyzed for obvious reasons. In pediatric patients, it can be used cautiously if we take into consideration the age and cognitive ability of the patient prior to the arousal failure. In addition, the lack of consensus as to the items used for scoring makes inter-institutional scoring not reliable. Eye-opening scoring in pediatric patients is much the same as in adults, except concerning the granting of 3 points to a patient less than 1 year of age for opening the eyes in response to shouting. The scoring of motor responses in patients over 1 year of age is the same as in adults. Patients less than 1 year of age are scored as adults, except when it comes to grunting, 6 points for spontaneous movements. Scoring verbal responses is more complicated. Patients older than 5 years of age are scored as adults. Between 2 and 5 years, 1 point is granted for no response, 2 for grunting, 3 for persistent cry and screams, 4 for inappropriate words, and 5 for appropriate words. From birth to 23 months, 1 point is granted for no verbal response, 2 for grunting, 3 points for persistent inappropriate cry and screaming, 4 points are granted for inconsolable cry, and 5 points are granted for smiling, cooing, or appropriate words. We have now covered the second item, and we will go on to the third objective. This objective is to describe the characteristic respiratory patterns, pupillary responses, motor patterns, and vestibular functions that help localize the site of the offending lesion in a patient with coma. So we have talked about the Glasgow Coma Scale, and we will address anatomical localization as a way to a more precise description of the degree of arousal failure. This method is based on determining the region of the neuroaxis involved. It is important to notice that changes in mental status occur relatively rapidly. Those exams conducted minutes apart may yield different results. This is the model that you have been seeing during this presentation. In it, you see here represented the ascending reticular activating system and the two wake connection with the cerebral cortex. I have now added a sagittal cut of the brain. The red area in the model represents the cerebral hemispheres, the purple area, the diencephalon, the blue area, the midbrain, the yellow area, the pons, and the gray area, the medulla. Involvement of each of these anatomical regions produces rather typical findings in 4 areas: respiratory, pupillary, motor, and vestibular. Let's start with respirations. Cerebral hemispheric involvement is associated with Cheyenne-Stokes breathing, which is characterized by periodic stereotypical crescendo-decrescendo breathing pattern followed by apnea. Involvement of the diencephalon also causes Cheyenne-Stokes breathing. Midbrain involvement produces hyperventilation. This respiratory pattern is characterized by fast respirations at a sustained rate with minimal variations in frequency and amplitude. Pons involvements may produce 3 types of breathing patterns: hyperventilation, just as with midbrain involvement. The second pattern is cluster breathing. Cluster breathing is a form of periodic breathing characterized by clusters of breath of irregular frequency and irregular amplitude, separated by pauses of variable duration between the clusters. This type of breathing is more common with lower pontine involvement. The third breathing pattern seen with pontine involvement is apneustic breathing. This type of respiration is characterized by prolonged pauses at the end of inspiration, as you can see in this frame. This pattern is more commonly seen with lateral tegmental involvement. In the lower pons, involvement of the medulla can produce two breathing patterns. Ataxic breathing. This is a non-periodic breathing pattern of irregular frequency and amplitude. The second type of breathing pattern seen with medullary lesion is called agonal breathing. This breathing pattern is characterized by infrequent deep breaths. It is important to remember that isolated medullary lesions do not produce coma. So we have talked about regional respiratory patterns. We will now talk about pupils. Cerebral involvement produces pupils that have traditionally been called metabolic pupils. These pupils are small and reactive. They occur with encephalopathy, usually metabolic, but also with encephalopathy due to poisoning. In this frame, you can see the arrow indicating the diencephalon. Diencephalic pupils have similar characteristics and causes than those seen with cerebral hemispheric involvement. Midbrain involvement can produce three types of pupillary abnormalities. One type is called midbrain pupils. These pupils are mid-size or large and fixed. Another type of pupil seen with midbrain involvement are called pretectal pupils. They are large and fixed. And in addition, they show prominent hypos. Hypos refers to the continuous variation in pupillary size. This phenomenon is found physiologically as presented in this graph, but it is exaggerated in patients with midbrain injury as represented in this new graph in red. The third type of pupil that can be seen with midbrain involvement is called third nerve pupils. The third nerve pupil is a very large pupil when compared with the pupil on the other side. The affected pupil is unreactive. Third nerve pupils are often called Hutchinson pupils. Hutchinson pupils are frequently the first ocular sign of uncal herniation due to the peripheral position of the parasympathetic fibers in the third nerve and the trajectory of the herniated tissue as indicated by the arrow. Pontine involvement produces pontine pupils. Pontine pupils are very small. They are often called ping-pong pupils. They are reactive if midbrain was not involved prior to the pontine being affected, and fixed if the pons damage occurred as a manifestation of caudal disease progression throughout the neuroaxis, reflecting midbrain involvement. Medullary involvement, when present in conjunction with pons and midbrain damage, is associated with fixed and dilated pupils. Isolated medullary lesions do not produce arousal failure nor affect the pupils. In this frame, you can see that I have summarized the most salient pupillary findings corresponding to each anatomical region. Stop the video, take time to look at this figure, and if you have problem understanding it, go back and look at the segment on pupils again in this video. After pupils, we will consider motor findings. With cerebral involvement, the comatose patient can localize pain, and withdrawal is usually possible. Once the diencephalon is involved and the cerebral connection to the red nucleus are not functional, the corticate postures ensues, characterized by arm flexion, the hands going to the heart, as you see in this frame, and the legs extended. In this frame, I have included a specimen depicting the intact red nucleus. The shaded area implies the affected area in this figure. With midbrain involvement, the red nucleus flexion facilitatory influence disappears, and the vestibular nucleus extensor influence prevails, producing deceleration characterized by upper extremity extension and leg extension. I have included a specimen depicting involvement of the red nucleus in this frame. With upper pons damage, the decelerated posture still prevails. More extensive pons damage involving the lower segment of the pons, as shown in this frame, leads to flaccidity because the vestibular nuclear damage deprives spinal motor neurons already deprived of flexor influence due to damage to the red nucleus of extension influences. Medullary involvement manifests by flaccidity for the reason stated before when referring to the lower pontine lesions. The last area I want you to consider is vestibular function. Vestibular testing is an integral part of the evaluation of the comatose patient. With involvement limited to the cerebral hemispheres, head rotation and cold caloric testing fail to trigger nystagmus because of the absence of the fast component. The slow component is present, driving both eyes against the direction of the head turning and towards the eye being irrigated with cold water. Head movement in the opposite direction, as depicted in this frame, and cold caloric in the opposite ear have similar results. The slow component drives both eyes against the direction of the head turning, and cold caloric slowly brings the eyes towards the irrigated ear. These results also establish normal functioning of the vestibular component of cranial nerve 8, cranial nerve 3 and 6, and their interconnections. With the encephalic involvement, vestibular testing results are the same. No fast component, but good cranial nerve 3, 6, 8, and interconnections. On the other hand, midbrain involvement produces significant changes in vestibular testing from those we saw with cerebral and diencephalic involvement. In these cases, the fast component, as expected, will be absent. Cranial nerve 6, arising from the pons, will be functional, thus pulling the eyes laterally against the direction of head rotation and towards the side of the cold water irrigated ear, but medial deviation of the eye will not occur, reflecting cranial nerve 3 damage. This will be the same when the head is turned in the opposite direction or when the cold caloric is done in the opposite ear. Pontine involvement will trigger further deterioration of vestibular function. With pontine involvement, head turning and ice water testing will fail to produce any reaction. regardless of the direction of the head turning or ear being irrigated. Involvement of the medulla courses with the same findings because of the destruction of the vestibular nuclei. I will now talk to you about false localizing neurological signs. False localizing neurological signs mislead neurological localization. They occur in two major contexts: as a consequence of raised intracranial pressure and with spinal cord lesions. Here, I will only address those related to increased intracranial pressure, and among these, I will only mention the two most frequent ones. One is cranial nerve 6 palsy. The presence of a cranial nerve 6 palsy suggests involvement of the pons, but in some instances, an increased intracranial pressure can produce similar findings. This patient had pseudotumor cerebri. In this frame, you can see papilledema and eye findings consistent with left 6 nerve palsy. The left eye is in because the left lateral rectus failed to keep it midline. The site of injury nor mechanical cause for the palsy is known, but it is believed that the palsy is produced by backward displacement of the brainstem due to increased intracranial pressure. This pressure exerts tension on the 6th nerve. The 6th nerve appears particularly vulnerable to backward displacement of the brainstem because it comes off straight forward from the brainstem, whereas other cranial nerves come off the brainstem more laterally. The second condition is Kernohan notch phenomenon. In this frame, I am illustrating the crossed innervation of limb muscles by the pyramidal tracts. The cream-colored structure represents the skull and the cerebellar tent. The magenta line represents the pyramidal tract going from the right hemisphere to the left side. The aqua line represents the pyramidal tract going from the left hemisphere to the right sided muscles. In the new figure, I have represented the same structures and in addition a cerebral lesion represented in red. This lesion is compressing the aqua line representing the ipsilateral pyramidal tract, thus producing contralateral weakness. I have now represented a similar lesion in the new figure, but this time the lesion is only displacing the aqua line, but pushing the magenta line representing the contralateral pyramidal tract against the tentorium. Pressure on this tract against the tentorium edge, producing weakness ipsilateral to cerebral brain lesion. This is called Kernohan notch phenomenon. This phenomenon is associated with third nerve pupil on the same side of the weakness. I have now introduced a CT scan showing a mass lesion on the left, and now an MRI of the same patient where you can still see the lesion, but more importantly, you can see a second lesion involving the opposite cerebral peduncle. This new study is a coronal MRI. In it, you can see the displacement of the midbrain to the side opposite to the location of the lesion and the tentorium pressing on the midbrain. Having finished with the third objective, we will start the fourth objective. Describe the clinical features of Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome is really two syndromes, one acute and reversible, Wernicke syndrome, This syndrome is characterized by nystagmus that gets worse in the direction of the gaze, lateral gaze palsy, ataxia, and confusion. The added term of Korsakoff implies chronicity and irreversibility. The clinical manifestations of Korsakoff syndromes are memory loss, confabulation, and psychosis. The anatomical lesion in patients with Wernicke-Korsakoff syndrome is scattered. The site with the most prominent abnormalities are the mammillary bodies. You can see in this coronal MRI the abnormal signal changes in the mammillary bodies, but also in the transverse view you can see pathology in the mediodorsal nucleus of the thalamus, and in the sagittal view you can see pathology at the periaqueductal region and in the pons. Wernicke-Korsakoff syndrome is usually due to vitamin B1 deficiency. Vitamin B1 deficiency is often seen in patients with alcoholism. You may see it in the ER presenting in front of your eyes if you forget, as I did when I was a resident, to give B1 to chronic alcoholic patients before you start an IV with glucose. Having completed this item, we will jump into the last item. The definition of 5 terms often used in neurology. The first term is vegetative state. Vegetative state is a chronic neurological condition manifested by lack of awareness of self and environment, presence of sleep-awake cycles, preservation of vital vegetative functions, such as cardiac function, respiratory, and blood pressure. Cranial nerve and spinal reflexes may or may not be present. MRI usually shows diffuse white matter lesion that predominantly affects the frontal lobes. Bilateral thalamic pathology is also often present. The second term is persistent vegetative state. The definition of persistent vegetative state varies. In patients with acute traumatic or non-traumatic brain injury, vegetative state, to be called persistent, must be present 1 month after the injury. In patients with degenerative or metabolic disorders or developmental malformations, vegetative state, to be called persistent, must be present for 1 month or longer. An alternative term for persistent vegetative state is persistent unresponsiveness, a term preferred by many neurologists. Another point of contention is duration. Some say 6 months for post-traumatic and 12 for non-traumatic. The third term is akinetic mutism. Patients with akinetic mutism look awake but remain silent, inattentive, uncommunicative, and motionless except for the eyes. The eyes dart in the direction of moving objects. Signs of frontal release or cortical spinal tract damage are often present. Most patients with this condition have bilateral frontal lobe, including anterior singular gyro lesions, as you can see in this MRI. Others have damage to the diencephalo-mesencephalic reticular formation. The fourth term I want to bring to your attention is lock-in syndrome. Patients with this syndrome lie mute and motionless, An alternative term often used to refer to these findings is the efferente cerebrum presentation. This is so because these findings result from the damage to most of the fibers leaving the cerebrum. Patients with lock-in syndrome are awake, alert, and capable of perceiving sensory stimuli. Sleep-awake cycles are present. They communicate by vertical eye and eyelid movements, since the muscles carrying out these movements are innervated from the midbrain. The lesion involves the descending motor pathways bilaterally in the basis pontis, thus sparing the midbrain as well as sparing the more dorsally located sensory, autonomic, and ascending activating reticular systems. In this MRI, the location of the lesion is indicated by the red arrow. The normal dorsal area is indicated by the green arrow. Were we to cut at the level of the white line, we would see a specimen as the one shown here. In it, I have traced the basis pontis. Behind this line, you can see the tegmentum. In this frame, I have enlarged the specimen to show you some important structures in it. The boundary between tegmentum and basis pontis is delineated by the trapezoid body, medial lemniscus, the spinothalamic tract or anterolateral system, and the lateral lemniscus. I have now drawn a line to highlight the differences between the posterior region, that is the pontine tegmentum, and the anterior region, the pontis basis. All the structures we just mentioned are sensory. Also in the tegmentum we find the reticular formation that forms part of the alerting system, the medial longitudinal fascicle, and a structure involved in lateral eye movements, the dorsal longitudinal fascicle, and the medial forebrain bundle fibers. The latter are not singled out in this specimen. They carry efferent and efferent autonomic fibers. In front of the line, we have the motor fibers. Here we find the corticobulbar and corticospinal fibers, the pontine nucleus, and the pontocerebellar fibers. It is a lesion involving these anterior structures that explains the finding in patients with lock-in syndrome. The fifth definition is brain death. Patients with brain death have no clinical evidence of cortical, subcortical, or brainstem functions. No brainstem reflexes including cold calorics and apnea test. No EEG activity. And no change in clinical and EEG status for 24 hours. This time criteria is not accepted by all, and in some institutions they vary according to the patient's age and the etiology precipitating the condition. In the United States, brain death protocols vary from state to state and from institution to institution. Some European countries' protocols are also different. Well, as promised, at the beginning of this talk, I will tell you the diagnosis and outcome of this patient. She had a condition called Reye syndrome. It is produced by a combination of chickenpox and aspirin. This condition is now almost eradicated by the use of chickenpox immunization and avoidance of aspirin in patients with chickenpox. She fully recovered, as you can see in this frame. Thank you for your attention.